Thank you. It's a pleasure to be back to talk to you today about ITP and about vaccinations. I've changed my topic a little bit, and I'm going to just mention this should be entitled, "What Should ITP Patients Know About Vaccinations?" These are just my disclosures. I haven't changed in the past hour and a half. And my goals today are to focus on an alarming report that was published in the New York Times on January 12th, 2021. And this is a patient who died after a COVID vaccination. This has led to a lot of consternation among patients in the United States about getting COVID vaccinations and vaccinations in general. And this is the motivation for my talk today, is to discuss a little bit about this poor chap's death, but also discuss in a broader term of vaccination. So my goals today are to make you all immunologists by telling you about the immune system. I'll talk about what vaccines are and how they're made. I'll mention briefly the role of vaccinations in patients with no spleens, which is an important message to hear. Then I'll focus on the causes of ITP from vaccination, if they do exist. We'll talk about, does vaccination worsen ITP if you already have that disease? And lastly, we'll talk about what does COVID-19 vaccination do in this particular context. So let me start by saying the immune system is a very complicated scheme, which I promise you I won't go into great detail on. We have a process in our body that if a virus comes in, it's foreign to us, and that's a foreign substance called an antigen. We have an immune machinery, which we all have, which is very good at distinguishing foreign things from our normal things. And we make antibodies, and we make lymphocytes, which can attack this foreign substance. And so when you're invaded by a pathogen, like an antigen from a virus, let's pretend this is a virus, the immune machinery makes antibodies and lymphocytes. The antibody then can attack the virus, as can the lymphocyte, and this destroys the virus in a very complicated way. But this is a simple cartoon as to how our immune system works to defend us from attack by viruses. Now, it's been known for many thousands of years that if you have an infection such as smallpox and get scarred from it, that if you go to take care of other patients with smallpox, you don't get reinfected. So the concept of immunity has been around for many thousands of years. And the history is quite challenging and interesting, but I don't have time to review that. But we've all known that if you get one infection, you're oftentimes immune to other infections of the same type. And this has led to the concern over the years is could we create something that prevents vaccinations, that would prevent infection without getting the infection itself? And this is where vaccinations come into play. And there are many types of vaccinations. There are vaccines where the antigen is given to you as a dead virus or bacteria, such as a cholera bacteria, or an attenuated virus, such as a polio virus, or an attenuated bacteria, such as a typhoid bacteria. We often use purified proteins or sugars called polysaccharides to give us a tetanus vaccine or a Haemophilus influenza vaccine. And finally, we've got this neat technique, which many of you might have been exposed to already, where we take messenger RNA that makes the antigen in your body, and then your immune system reacts against that antigen. This is how many of the COVID vaccines are made. So we have these antigens which we are exposed to with the expectation our body will respond to them. And then when the real infection comes to us, we're protected against the infection. Now, one problem with using these attenuated viruses is they're not quite as strong as the natural infection. And so many vaccines have other substances added called adjuvants. And this is an important story. And an adjuvant is an ingredient used in some vaccines that creates a stronger immune response in people receiving the vaccine. In other words, adjuvants help make vaccines work better. And this is a quote directly from our Food and Drug Administration. And adjuvants can be the antigen itself. Dead viruses and dead bacteria are very strong, potent stimulators of the immune system. We add aluminum salts to many proteins to create pneumovax. This increases the immune response. Lipids and DNA, and also the mRNA that's used in our current COVID vaccines are all things that stimulate our immune system. And so we have an antigen and an adjuvant, and these two together hasten our immune response. And to give you a very brief overview, and I apologize for the science here, but basically if I inject you with an antigen and an adjuvant, the adjuvant retains the antigen longer under your skin or in your muscle and gives us a slow release form of the antigen. This adjuvant also increases things called cytokines, which stimulate our immune system. And this causes immune cells to go to the antigen right here, and it hastens our immune response. In addition, if this is the immune cell we're talking about, and this is called an antigen presenting cell, if you have a new virus taken up through this cell, the adjuvant stimulates its uptake, It stimulates activation of these immune cells. It also stimulates the processing of immune substances as antigens. And this called antigen presenting cell then migrates from your injection site to your lymph nodes. And here it makes lymphocytes become what are called B cells that make antibody, or T cells that give you an immune response, which is due to the lymphocyte itself. So this is the genesis of how we make antibodies and T cells that respond to infection. So if you have a viral infection, we usually have an antibody response and a lymphocyte response, which can occur. And these are all hastened or made much better by having an adjuvant added to the vaccine. Now, these adjuvants, as we'll talk about in a minute, increase and activate our immune system. So before I go to vaccinations per se, I want to put in a plug for an important statement that many of you in the audience may already know, that if you don't have a spleen, it's important to be vaccinated for certain pathogens, certain bacteria. And there's a topic which I don't want to go into too much called overwhelming post-splenectomy infection. OPSI is its bad acronym here. It sounds like a British spy agency, but I won't go down that road. The spleen controls infection from bacteria that have capsules. It's like an M&M with a sugar capsule around it. The three bacteria are Streptococcus, Haemophilus influenza, and Neisseria. If you get infected with this is a rare complication, but it has a very high mortality rate. This is a bacterial infection in the blood, causes low blood pressure, causes organ failure, and most patients end up in the ICU. There's a lovely group in Australia called the Victoria Spleen Registry. All patients who've been splenectomized are monitored and are tracked. This is 3,000 patients. About 500 had infections, and only 47, about 1.5%, developed this serious infection. So it's about one event per 1,000 patient years. But to be honest with you, other studies have shown that over your lifetime of having no spleen, the risk of having this major infection is as high as 3%. I think this is an overcall. And this is why vaccinations are strongly recommended in this situation. No one has ever proven they work, but it's our recommendations from almost all governmental agencies. Now, what you're trying to prevent, and this is a gross picture that I want to show you that you may want to turn your head aside for a second. It's like the declarations on TV that the following may upset you. This is a guy who's got bad infection. He's necrosed or killed off some of the skin on his leg here. He survived this infection, but he lost a fair amount of tissue. He lost his toes as well. But this is what this very bad infection looks like. So not to scare you too much, but this is what could happen if you don't get adequate vaccinations. And hence, almost all groups, the British group, the CDC in the United States, recommend that you get 2 different meningitis vaccines every 5 years, that you get 2 different pneumococcal vaccines shown here every 5 years up to age 65. And I'm happy to provide this recommendation to you if you don't already have it on your ITP websites. And finally, 1 Haemophilus influenza type B bacteria vaccination. This is 1 dose that lasts for life. Please note, this is not the flu vaccine. Haemophilus influenza was thought to be the cause of the 1918 flu epidemic, but was proven wrong many years later. This is a bacteria, not a virus. So having said that, let's come to the important topics. Do vaccines cause ITP? And the answer is probably yes, but incredibly rarely. This is a data-driven field which has very little data to it. And I'll simply give you some examples. Vaccines are commonly associated with ITP since they're commonly given, but it's uncertain if they cause ITP. So there's association and causation. These are 2 different aspects in medicine. Many different vaccines have been studied. The MMR vaccine, the Haemophilus influenza vaccine, hepatitis B, zoster vaccine, polio vaccine, pneumococcal vaccine. All of these have been associated with ITP, but it's very hard to find data if they actually cause ITP. And I'll come to the one exception that I can find in a second. If you look at the influenza outbreak in 2009 and 2010, and look at what's called UDRA vigilance data, this looks at immune negativity after a vaccination, you can see that some immune things happened at a high frequency after this vaccination. This is a thing called Guillain-Barré syndrome, which is a neurologic disorder, which is immune-based, but close behind was ITP. And if you analyze these patients did have ITP, but the problem you face is that it was occurring at the same rate that it would have occurred had the patient not gotten a vaccination. So this data with the flu influenza did not show any association, but not causation of ITP. Furthermore, a study by our colleagues across the channel in France looked at 198 French cases of newly diagnosed ITP. They looked at 178 patients who didn't have ITP that were matched by age and gender. And they asked, what about vaccinations in the preceding 12 months? If you had newly diagnosed ITP, a third of the patients had a vaccine. Those with no ITP, a third of the patients had a vaccine. And their conclusion was that at least in adults, there was no strong association of vaccination with the cause of newly diagnosed ITP. Now, if you search the literature, is there any data at all to substantiate vaccinations causing ITP? And the answer is probably in only one disease I can find, and that's it. That's the MMR vaccine. If you look at kids 12 to 23 months of age, and this is the date of the first MMR vaccine, there's a spike within the first 6 weeks of having an increased risk of ITP. That spike disappears later on. And if you look at the very lovely databases, which your country has, which the United States doesn't, and these are many different UK databases, you can look at kids 13 to 24 months old. And the take-home message here is there's a 6.3-fold increase in ITP in the first 6 weeks after getting the MMR vaccine. This was rapidly treated with corticosteroids, but this is a true association. I think it's valid. The risk disappeared after month 6, and it was thought to be that 1 in 25,000 patients who got MMR might develop ITP in the first 6 weeks. So this is the only data we have that suggests that ITP could be caused, at least in kids, from a vaccination. Now, how might this happen? I said before that we make antibodies against foreign viruses, but if a platelet looks a bit like a foreign virus, that antibody might attack your platelets. The lymphocytes might also attack your platelets, and lo and behold, we destroy platelets. So this is called molecular mimicry. It suggests that an antibody may what's called cross-react with the platelet and destroy it. In addition, when you have a vaccination, a second thing that might give you an unwanted problem is the vaccination might enhance your overall immune system. Again, we have these adjuvants that boost up our immune system. I don't have a good cartoon, but if you look at your immune machinery here, if you get a vaccination, it might boost your overall immune system to make you make antibodies against things that you shouldn't. This is a speculation. This has not been proven. Well, what about COVID vaccination? And this is a patient of mine who's never had ITP. He's a lovely 76-year-old lawyer. He has other medical problems. He's on the anticoagulant drug rivaroxaban. He got his first Pfizer vaccination. A couple days later, he developed petechiae and black stool. And after 7 days after the vaccination, he came to our emergency room with a platelet count of 1,000, previously normal, a hematocrit of 33, previously 45, and he had a low platelet count. He had a whole bunch of tests looking for antibodies against his platelets, which we didn't find. He was treated with prednisone and IVIG, and his anticoagulation was held. I have gotten about 150 phone calls in the United States after this very same kind of scenario. I got one a few minutes ago before I came to this talk. And this is this chap's course: normal platelet count, gets the vaccination at day 0, drops to 0, gets IVIG, gets prednisone. His platelet count is now normal off prednisone. He's now got a couple more data points out here, but he illustrates something which I think does happen. And this has been the subject of a recent publication that came out a couple weeks ago. I'm going to say that these are all my friends who published this article. I think they did it in haste, but I'll simply say that they did it. They looked at the first 20 million vaccinations in the United States, in which a vigilance system reported 17 cases of ITP, including that one guy in New York who died of ITP. They found that this occurred within the first 5 days. On average, ITP began 5 days after the vaccine. The average platelet count was 2,000, which is pretty low, as you all know. Most responded to corticosteroids or IVIG, and only one patient, the one who made it to the New York Times, died. They did some, I think, rather crude statistical analyses and thought that these 17 cases of the 20 million reflected the background rate of ITP in this patient population. They also commented upon the fact that in the 170,000 patients in the licensing trials for COVID-19 vaccine, no patients with thrombocytopenia were reported. So this is the data which is available. I think it is an issue, but it's not a huge issue since it's a 1 in a million occurrence. And I get phone calls, but most of the time it's due to other causes for thrombocytopenia. But this does bring a lot of caution to patients. So I think right now I would simply say that at this point it's unclear that the vaccinations cause ITP in this disease or in any other vaccination situation. We need more data. Well, what about if you already have ITP, like many of you have in the audience today? Does a vaccination make your ITP worse? And I can certainly give you many anecdotes of patients with ITP who get a vaccination and crash their platelet counts. But is there any data here? And I'll come back to the one situation, which is the MMR vaccine for kids. Again, this is 3 studies which are published. They're all from the UK when I praise you for your good databases. And they ask one question. If a kid got ITP after the first MMR vaccine, and you're supposed to get a second one, what happens after the second vaccination? And it so happens that a lot of kids got a second vaccination. In this one report, 0 of 11 patients had return of ITP. In the next one, 0 out of 21 patients had relapse of ITP. And finally, 0 out of 33 patients had relapse of ITP. So this suggests, at least for MMR, where the data is pretty clear that ITP may be caused by the MMR, that a revaccination did not cause return of ITP. This is the only data that exists, and we as your ITP docs ought to generate better data in this field with other vaccinations such as the flu. Which brings me to my second case. This is my very favorite 34-year-old ITP patient. I've known her for almost 20 years. She's got no spleen. She also has a thing called anti-phospholipid antibody syndrome and is on warfarin because of prior strokes. She has infrequent crashes, but her last crash was after I gave her meningitis and pneumococcal vaccine. She dropped her platelet counts to 0 within a week, and she got treated adequately, and she's now maintained an azathioprine with good platelet counts. In January of this year, she had a normal platelet count and no detectable antibody against platelets. I said to her, gee, you might be in remission after all these years. She got the first Pfizer vaccine on February 8th. 3 weeks later, she got the second Pfizer vaccine, but had fever, didn't feel well, and developed petechiae. 2 days after vaccination, her platelet count was at 19,000. I held her warfarin, gave her some prednisone. 4 days after the vaccination, her platelet count was 7,000. She was admitted to the hospital, got IVIG and corticosteroids. This is her course. This is her first COVID vaccination here. Here's her second COVID vaccination. Her counts might have dropped a bit after the first vaccination. I didn't check them in here, and she was not wanting to do this, but she did crash symptomatically here. She got IVIG. She got prednisone for a short period of time. Her platelet count soared back up, and right now she's stable, and another platelet count out here shows stability. But this is a situation which has forced us in our practice to actually look at all of our patients, and we now have a program for our ITP patients to give patients some courage and some support, and also to give me some information. If you look at the last 50 patients we have prospectively analyzed and followed after their COVID vaccination, we have some patients who had no symptoms but also didn't get platelet counts checked despite my recommendations. So a third of all patients had no troubles out of 50, but we didn't check platelet counts. Another half of my patients, 26, had no symptoms. We did check their platelet counts after the vaccination. There was no drop. And finally, we had 7 patients who had their platelet counts fall significantly. 3 of those 7 were admitted to the hospital. All 7 had their ITP treatment increased. All recovered in 3 to 10 days. One patient who I discharged from the hospital yesterday took 35 days to recover. Half of these patients had previously crashed when they were given other vaccinations. So I was a little bit prepared for these patients, but this is our current practice. So about 14% of patients have had troubles after they got the COVID vaccination. What I don't know is whether we'd given them a flu vaccine and followed them in a similar fashion, or a shingles vaccine, whether the same thing would have happened. I don't have that data. This is a defect in our ITP literature base. Finally, let's talk about Rituximab briefly. What if you've had Rituximab in the last 6 months? For any vaccination, it might not work. We have excellent data, which is very hard to show, and I'll show you that Rituximab sort of knocks out your immune response to vaccination for 6 months. This is patients who got the influenza vaccine. This is hard data to show. I wish these guys had made better figures, but these are healthy controls. Here's the antibodies against the influenza before you get vaccinated. After the vaccination, it rises about 5 to 6-fold. But if you've got Rituximab, and this is hard to show here, the horizontal line here didn't change. in patients that got the vaccination. So patients who had rituximab here didn't respond in any way as they should have done to the vaccination. So I think right now my summary, and I'll conclude here, is vaccinations are important in ITP patients to preserve health. Asplenic patients need to be up to date on their vaccinations per country guidelines. Vaccinations may very rarely cause ITP, particularly MMR. There's no data in adults yet. Vaccination may decrease platelets in stable ITP patients. COVID-19 vaccines may very rarely cause ITP, or more likely lower platelet counts in patients who already have ITP, but get vaccinated. If you've had a prior vaccination troubles or just are worried, get a platelet count 3 to 5 days before and after the vaccine. And finally, and this is important for those of you that might have had rituximab recently, rituximab treatment prevents adequate response. If you are uncertain if you had a response because your immune system, you can get a spike protein antibody level, at least in the United States, to check this. It's not the standard COVID antibody testing. This is a special test that identifies your response to spike protein vaccine and answers whether you've had a response or not. On that, I'll stop, and I would look forward to hearing your questions later on. Thank you.